There is not one canned elevator speech, if you will, that will say, this is what clinical nurse specialists do for everybody, because it changes slightly depending on the area of healthcare and the specialists themselves and what their background is.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
This week on First Case, we speak with Brenda Larkin, perioperative clinical nurse specialist currently working in Central Oregon. And Melanie, I'm really excited to talk to Brenda today because she is a clinical nurse specialist, but specifically working in periop. And so I don't know that I've ever heard of a clinical nurse specialist working in surgical services. So not only am I interested to hear about what role she plays in this environment, but also how her background and experiences have really led her career to this point.
I'm really looking forward to talking to her too. I've never seen a clinical nurse specialist in the ORs where I've worked, but that's a role I'm interested in. When I was looking at potential postgrad degrees, I was really interested in the clinical nurse specialist. So to hear what she does and to hear how she integrates that role into perioperative services and makes it all work and adds value and benefit to the OR is something I'm really interested in hearing about to see how she does it.
Yeah. All right. Don't go anywhere. This is going to be a very interesting and engaging conversation and a very new and fresh topic here at First Case. We're going to be right back after a short break with Brenda Larkin.
Hi, I'm Paul Wafer.
I'm Melanie Perry.
I'm Jeremy Gibson-Rohr.
And I'm Justin Poulin.
A 17 Studios production, you're listening to First Case.
Joining us now is Brenda Larkin, perioperative clinical nurse specialist, currently working in Central Oregon. And Brenda, I'm so glad that you're joining us today to talk about the role of the clinical nurse specialist. And so thank you so much for coming on the show.
Well, thank you for having me, Justin. It's a pleasure.
So why don't we just have you tell us a little bit about your background, not only as a clinical nurse specialist, but, what brought you to healthcare? Tell us the story.
Oh, that's an interesting story. I started out actually in pre-med in university, got my pre-med degree in liberal arts and sciences with a physiology concentration, and was planning to look at medical schools, but there was some nagging in the back of my mind saying, this isn't really the path you want. And so I did some hard thinking, and my mother influenced me greatly. She had never mentioned this before, but she said, what about nursing? I'm like, yeah, nursing would work. Then I don't have to have 24/7 accountability, and I can go home and raise my own children and that kind of thing in the future. So I started investigating nursing school, ended up at the University of Illinois in Chicago nursing school and graduate from there, and started my nursing career in obstetrics in Chicago.
Wow. So how did you go from OB all the way over to clinical nurse specialist? How did you get there?
Well, first I had a stop in the operating room where I transferred after 6.5 years working in obstetrics and became an operating room nurse. My place of employment was affiliated with a college of nursing, so there was the opportunity for advanced education. And I particularly liked their model of having a nurse practitioner expert on the units who was a master's prepared nurse and essentially doing the functions of a clinical nurse specialist. And I wanted to emulate that. And so I got a degree from a different college of nursing, my master's degree. The degree is actually in surgical nursing, but I have all the qualifications for the clinical nurse specialist concentration. It was not offered as a clinical nurse specialist degree at that time. It was really early. In fact, the year I graduated is when the first textbook of clinical nurse specialist came out. So I was a little ahead of that time.
So let's start with what the role of the clinical nurse specialist is. And it's great that you have that operating room background, because we're going to tie all that together, as we go through this conversation. But I think it's a little bit more broad of a description of the role of the clinical nurse specialist. Am I right?
Right. No, clinical nurse specialists can work in any specialty of nursing. The key is having a specialty area of focus. The other thing is that it's at least a master's degree, or now it's merging into the doctorate of nursing practice degree. So most institutions are offering that at a DNP level. And again, with a specialty of focus, my specialty is officially adult health. And so I have a certification in adult health, clinical nurse specialist from the ANCC, as well as a CNS certification for perioperative. So I have two different certifications to cover all the areas that I would normally cover. So I cover, health across the lifespan in the OR, plus being in the OR. So clinical nurse specialists are one of the 4 advanced degree nursing categories that there are. Most people are familiar with nurse practitioners and certified registered nurse anesthetists. Certified midwives are also part of the advanced practice nurses, and clinical nurse specialists. The clinical nurse specialist is a little different than the other 3 because we don't necessarily always have direct patient contact. We are more concerned with systems, implementation of evidence-based practice, and really assisting the nurse at the bedside to deliver that evidence-based practice to the patient.
What you just said about how it's not necessarily direct patient care, but you're interested in the systems and in the helping the people at the bedside implement the systems. But the clinical nurse specialist is the degree that I looked at myself as possibly going on when I got my master's, or now you're scaring me because you said potentially doctorate. But how does it incorporate into the OR? I mean, if I'm an OR nurse and I want to be a clinical nurse specialist, what's that going to look like for me?
So if you're going into the clinical nurse specialist degree with a focus on the operating room, you would be looking at being kind of like the nurse's nurse, or in other words, being the nursing instructor that's available to the nurses to help them with problem solving, complicated cases, planning, integration of evidence-based practice at the bedside. So new measures of, let's say, surgical site infection prevention measures could be a role that I would do in the operating room. Also, education and training of new nurses to the operating room is a big component. And I share that responsibility with OR educators if there's an OR educator at that facility. Sometimes I've done it all myself. So both educator and practice expert.
So Brenda, what exactly is the difference between being a CNS and a perioperative educator? I mean, is there a gray area between the two, or what? Maybe the question to ask is, what can you do that an educator can't do?
Sure. Well, educators are generally baccalaureate prepared nurses that are experts in their area, for instance, operating room. What I do is I can develop programs of education, and also I am oftentimes leading or facilitating interdisciplinary teams to improve some system element, some process, like introducing a smoke evacuation cautery pen into a facility that does not evacuate surgical smoke. So that means I'm going to be working with physicians, anesthesia, hospital administrators, the leadership of the OR, and the end user, the OR nurses, as well as everybody else in the operating room to facilitate the whole team in moving forward. An educator is usually somebody who will do onboarding, orientation, ongoing competencies, just-in-time education, and would also arrange for in-services from vendors as needed for new products or as a refresher.
I see. So it is a different role, and that makes sense, that division there. So what's a typical day like for you? How much time would you say you spend in an operating room helping folks to understand a new process versus in an office developing a program?
Sure. Well, I'm really happy that my day varies from day to day. So I have no one day that is different from another, but I do have a lot of time that I spend in the office as well as interdisciplinary meetings. I integrate with safety, infection control, the surgery section meeting of the physicians for all the specialty surgeons and anesthesia. And so sometimes I refer to being in the OR as a vacation because I'm away from my computer and away from my desk and I can be where the action is. So it really just depends what the needs are for the day or what the focus is on as far as if there's an implementation that needs to be seen and guided through the operating room and to assist staff with something new, or just to assess practice at the bedside to make sure that we haven't drifted off line from our guidelines and practices. So it all depends.
So Brenda, in your role as a clinical nurse specialist, is that a role that's maybe in addition to your other OR leadership, like your manager and your director, or is that something that maybe the OR director or the OR manager carries that certification to, and they also do that job, or is leadership and clinical nurse specialist completely different?
Usually management is different than clinical nurse specialists. There, unfortunately, aren't a lot of people in the U.S. that are perioperative clinical nurse specialists at this point. So having a clinical nurse specialist is kind of a bonus in addition to the normal leadership of the OR and educator. So it's a great addition in order to move forward with nursing practice and also medical practice, because a lot of times physicians will want to do some new procedure and the operating room staff needs to be prepared for that new procedure. And that's something I can come alongside an existing educator and assist with, if not do myself, depending on, who's got more work to do at the moment. So where you asked about overlap, yeah, there's a lot of overlap, and that can be confusing. But, sometimes two brains are better than one, right?
What are some tips to make it less confusing? Like you said, how do you get that kind of clarity? Because I think everybody knowing their role and being able to work collaboratively is really critical. And especially where you're focused on systems, I got to think you have that whole process mind. And so that's got to be ever present as you approach your role.
Right. I mean, that is the age-old question for all clinical nurse specialists. How do you scribe your role? How do you enact your role? I can tell you when I trained back in the 90s, I was precepted by a clinical nurse specialist who did collaborative practice with a physician, and I was expecting to do that. But when I got my first clinical nurse specialist job, I was a unit-based clinical nurse specialist. I had to relearn the whole paradigm from that perspective. So it's a constantly evolving, changing career path in nursing, which makes it more difficult to explain to people exactly what we do. There is not one canned elevator speech, if you will, that will say, this is what clinical nurse specialists do for everybody, because it changes slightly depending on the area of healthcare and the specialists themselves and what their background is.
So, Brenda, I've got a couple more questions that have just come to mind. The first one being, I know that in many operating rooms where there's an educator, the educator will sometimes end up getting pulled into a case because either there's a staffing issue or something comes up and they need an extra hand in the room. Does that happen to you? I mean, do you ever end up getting pulled into a room to help out, getting pulled out of what you were doing to do that?
That has happened on occasion, but it's very rare. And there's usually some other reason why staff want me present and either scrubbed in or observing in the operating room. And it's not to do staffing. In fact, I make it a practice, since I've done the clinical nurse specialist role in the operating room, to not staff. So even though I understand the documentation electronically, I'm not expert at it. I am not proficient at it. I can babysit an OR case, meaning I could give a circulator a break or lunch, or I could scrub in and help out but I could not be the primary scrub anymore because I have purposely let those skills go by the wayside in order to enact my role more fully on the other side of things.
That makes sense. So here's another question. What about gaining credibility with the physicians? Has there been any challenges in terms of being able to be accepted in your role with the medical staff at your facility? Do they understand your role and take advantage of your expertise?
Well, I'm currently at a newer facility, transferred to it last fall, but based on experience from my previous facility where I was at for quite a few years, it does take a little time for physicians to understand how I can help them with their system problems, because a lot of the things that they want change impact other systems in the hospital, other departments. And so being that bridge to get from what they want to how it will actually work in the hospital takes time and understanding, and building on successes really helps with the buy-in of my role in working with physicians. I can say that most of the times the early adopters are the anesthesiologists. And so I've had real great successes working with anesthesiologists and helping to solve their problems.
I got to think that there's a pretty critical human element here. And I just really love hearing operational and systems. And it's right up my alley. So I get excited when you start talking about that. And I know you could be somebody who really understands those systems and the impact and the complexities. But if you don't have the ability to move people, as you were just alluding to, you might still fall quite short of the goals that you've set for yourself. And it almost sets you up as a clinical nurse specialist to really have to be a jack of all trades. You really have to have a very wide skill set. Would you agree with that?
Yes, I think one of the most important things for a clinical nurse specialist in a hospital-based setting is being able to integrate with all the other departments in the facility that you need to have in your back pocket, if you will, in order to move certain projects forward. I do a lot of work with infection prevention, with quality and risk, and even with the C-suite sometimes. Things go to that point where you need C-suite buy-in. And so to be able to know who to contact and when and why, and then execute that takes time, and it's kind of a trial by error method, because there's no real roadmap to say, welcome to your new job, and here are all the key people and their contacts. You have to kind of go seek them out.
So if you're spending so much time, and it seems like you need to be, with all of the things that you have to do in your role, but you're outside of the OR working with other departments and integrating all of those different departments together, how do you make sure that you stay on top of staying relevant, I guess, with surgery and knowing what's going on in current practice? How do you stay on top of what's happening in the OR?
Sure. Well, I am a member of AORN. In fact, I've served as a National AORN Board of Director member for the last 4 years up until April this year. So that has really enhanced my knowledge of what is currently going on in the field of operating room nursing, as well as, I consistently read the AORN Journal and other surgical magazines that are published to see what's happening in outpatient areas, because I used to have a freestanding surgery center as part of my overview. And so I need to know what's happening. I also had to adapt to knowing and overseeing the practice of GI lab. So, that's a little bit different. Depending on the size of the facility, you might have other people doing that. So, yeah, you do have to do a lot of study and keeping current with contact hours and different trends in the industry, and even keeping track of the mergers and acquisitions of the healthcare device companies. Yeah, that can be a full-time job too.
Yeah, definitely.
Brenda, that whole part about infection control and just like surgery and then GI, that's even more of a jack of all trades just in terms of content and subject matter expertise. That's really broad. And I actually do another podcast called Transmission Control, which is targeted towards infection control and preventionists, both in the acute setting, hospitals and long-term care and non-acute. And I can tell you one of the areas that they experience the most discomfort, unless they came from surgery, is surgical services. And so having somebody on the team who really understands that, I can see what an asset you could be to really complement infection control, because they have to work in all the different areas in the hospital, not just surgery. And so I see where your role can be so complementary and fill in some of those gaps. And it almost seems to me like that's your job, to figure out where there's a gap and then fill that, but not just fill it as the person who is bringing that extra level of expertise or focus, but also to fill it in an operational way so that that hole stays closed and you can continue to go and improve the system. The way to do that, I think, and one of the challenges I would assume, is trying to learn all that information and become really, really knowledgeable so that you are that resource. And as you mentioned, you could be bouncing around doing different things. There's no playbook. I think your involvement with AORN highlights one of the ways that an individual could be super successful in that role, which is networking. You clearly went to an organization that was going to help you get credible information. You networked with people. You got involved. Super important, get involved to establish those relationships. Do you find that that helps you really expedite your learning and your access to credible information to then be a resource yourself?
Yes, that really helps. The other thing that I think is maybe just unique to me is I have worked in every conceivable operating room scenario that there is, from office-based surgery, small rural community hospital, freestanding, ambulatory, and quaternary medical center, academic medical center. So I have a broad background for the operating room in different ways that it can be practiced as far as operating room nursing and seeing the different subtleties. Plus, I've also scrubbed and circulated, whereas a lot of nurses these days are not taught to scrub in. So as far as interfacing with the certified surgical technologist, I understand their role completely because I used to do it. So I can be more helpful to their career development as well.
Brenda, I'm wondering if you could give us an example of a time when you were able to enhance the practice of your staff in the operating room, whether it be at your current facility or at a prior facility. So it kind of brings home what you're able to do for an organization. Because I think the role of the CNS in the OR is wonderful, and I'd like to see a lot more facilities adopt that in the future.
Yes, thanks, Paul. I think that one of the programs that I implemented along with the Shared Governance Council of the OR at my last institution was a back to basics effort, because all of us learn, practice, and then there's times when we drift away and we're not quite practicing exactly right, and we need to be moved back to center line. And so we developed an educational emphasis on moving back to practice that was shared in the in-services and staff meetings, as well as created a poster that I could put in the OR at specific areas, whether it's in the OR suite or just in the hallways, as a reminder to the caregivers, this is what we should be doing, so that everybody was more aware of the problem-prone areas and would be able to then self-correct or help others correct at the bedside.
What about staff that need remedial training? Do you end up getting involved with that? I mean, or is that the educator that does that? How do you help someone improve their practice on an individual basis?
So it's been done both ways in my experience. Sometimes the educator is charged with that process and sometimes it's me. It just depends on what the resources are for the facility and who's available to do it. I've had some really good results with some serious staff practice issues and helping staff overcome the issue and achieve a better practice level. And that's usually done in concert with the OR manager in a more, I guess, formal manner, as well as, as I'm in the OR and I see something that's wrong, I can course correct at that moment and say, so-and-so is contaminated, or this fell off the sterile field and is contaminated. I need to replace it, and just be those extra set of eyes to maintaining the sterile field. So, from that point of view to major things. If someone is in need of more remedial or even disciplinary practice, I can come alongside OR leaders and help assist with that process as they need it. Sometimes, it's not needed.
What about the pre-admission testing process and pre-admission process the day of surgery? Do you get involved, and PACU? Do you spend time in those areas as well?
So currently I am focused just on the operating room, but in my last organization I had, pre-op, pre-anesthesia call, PACU, the GI lab, as I mentioned, and the OR, and I also assisted with interventional radiology as needed. So I was required to learn what was best practice for all those areas. And so, yes, I did get involved back in the day when the implementation of all the surgical infection prevention strategies were being done with the SCIP initiative. I assisted the infection prevention team and the rest of the OR team to implement the proper pre-op bathing regimens. And this was a system-wide project, so there were other clinical nurse specialists or nurse specialists that were in training assisting in that process depending on the whole system. So we implemented the infection prevention measures necessary for pre-op bathing, day of surgery bathing, hair removal, and antibiotics and proper skin preps and the whole bundle that way. And we did the measurements for that.
I have one final question on that is, are you involved with any of the enhanced recovery after surgery efforts? Any bundles or anything of that sort at your facility in terms of trying to get those implemented?
So currently at my current facility, and I've only been there less than a year, I have not been involved in any of those initiatives for them, but I have been on committees for the ERAS protocols for total joint patients as well as colon patients that we were implementing at that time.
So, Brenda, we're just about to wrap it up, but I kind of wanted to ask you one last question that I think for anybody out there with career aspirations, and you talked about, the 4 different areas and clinical nurse specialist being one of those, but it occurs to me that this focus on systems and sort of that operational aspect, it's probably the best path if you want to move towards that CNO position, if you want to be moving up that ladder. Would you agree, just that comprehensive understanding of the facility, that the CNS, is really a good way to go if you want to become a chief nursing officer at some point?
Well, actually in academia now there are several tracks for doctorate of nursing practice, and one is in healthcare leadership specifically. That doesn't mean that a clinical nurse specialist couldn't cross over to doing OR leadership as a career path. One of the things that I enjoy most is the variety of my day, and that I'm interfacing with all sorts of different individuals that contribute to the healthcare team and their processes. So that's really keeping me in the practice side versus the leadership of management side. And so it's just depending on what you want to do. I was tracking more leadership at one point, but it's really not my heartstring, for me, and would not fulfill me if I did that job, even though I could possibly do it.
Well, you did a wonderful job on this podcast. So you could absolutely do that. It would be great to have you back again in the future season.
Be glad to be back and contribute to another podcast.
Yeah, we're just scratching the surface, I can tell. So, and I think we really enjoyed what you had to say about, having that variety of experience and the perspective, of the scrub and the surgical technologist and how important that is. We've had a number of episodes very recently talking about that. And so you emphasizing the importance of that was very timely today. So I want to thank you for that too.
Well, it is a team effort. We can't do what we do without the whole team. So, yeah, being able to support everybody is really a privilege that I have.
And that was Brenda Larkin, perioperative clinical nurse specialist, currently working in Central Oregon. Paul, I really enjoyed this one. One of the things that I really liked about it was how much she enjoys not being put into a box in terms of her role, but there's almost an entrepreneurial spirit to the work that she does, where she really has to look around, figure out where the opportunities are, corral the troops, so to speak, to get initiatives moving forward and fill some pretty big needs. And, I know that you found her, just kind of researching potential guests and the role of the clinical nurse specialist. But how many different facilities have you been in, Paul, where you saw a clinical nurse specialist dedicated to the OR or supporting the OR? It sounded to me like it's a fairly uncommon practice.
Justin, I can tell you that there are very few. I can't think of one, honestly, and I've been to probably 100 different hospitals in my consulting role, and I don't think I have met any other clinical nurse specialist in the operating room. And for me, this was really terrific to learn the differences between what a clinical nurse specialist does versus an educator, and how they have to really know best practice in all of the perioperative settings and the whole OR environment, so that they can keep people going in the right direction and providing best practice and best care to their patients. So I think it's a really important role. I'd love to see more hospitals adopt the CNS role in the operating room. It's truly needed, and it's for the whole continuum of care, not just surgery.
Yeah, and she's so multifaceted. I mean, talk about surgical services all the way over to GI lab, and then we dove to scrub and surgical technologist and just all of that experience and knowledge. What an incredible resource not only Brenda is, and she even said uniquely to her skill set and experience, but really it just seems like it'd be so important for a clinical nurse specialist to be able to understand lots of different things and to bring different perspectives and be that resource. So hopefully it does expand, because it does sound like to me that there's a huge opportunity to integrate this into the ORs all across the country.
Oh, for sure. And you think about we talked briefly about enhanced recovery after surgery, and that's taking that whole perspective from prior to the patient ever getting scheduled through the OR and recovery process. That's where I think a clinical nurse specialist has a really big role to play in the future. And there's going to be more and more of those bundles for enhanced recovery that are going to be coming in the future. Definitely a terrific role, and Brenda did a wonderful job for us today.
Yes. Thank you, Brenda, for joining us. That's going to do it for this week's show. As a reminder, you can help support First Case by subscribing on iTunes, Stitcher, Google Play, and Spotify. We certainly appreciate a rating and a review, because your feedback is important to the show. And definitely check out our new app for iPhone and Android. Just search for First Case in your app marketplace. On behalf of Melanie and Paul and myself, thank you for listening to this episode of First Case.